respected leaders of Indian Medical Association and friends of our modern medicine profession. Greetings from Indian Medical Association, College of General Practitioners, Kerala. Dear friends, IMA CGP, as you all know, is the oldest academic wing of Indian Medical Association. Here, we are for empowering every medical practitioner across the country, if not the majority of the world. Our attempt through this program, Essentials of Modern Medicine for Everyday Practice. This Thursday weekly webinar is presented to you on behalf of IMA CGP Kerala State. Today, we are blessed with the presence of the State President-elect of Indian Medical Association Kerala State, Dr. Gokulam sir. We'll not have another formal, addresses today, except Gokulam sir is here. So let us listen from Dr. Gokulam sir for a few minutes, and then we'll directly go to the academic session. And henceforth, we'll have the academic session from 8 p.m. to 9 p.m. on every Thursday as planned. Today, we are blessed with the presence of Professor Dr. Bhasi, Professor Emeritus of General Medicine Department, Sree Gokulam Medical College. We also have the presence of the Dr. Viju Nelson, our State Secretary of IMA CGP Kerala State. We recognize the presence of many senior members of the profession and as well as the fraternity. Dear friends, let us hear from Dr. Gokulam.
Good evening, everyone. Respected Bhasi sir, Dr. Prashant, Director of Studies, IMA CGP, and Viju Nelson, Secretary, and my dear IMA members. Now, Indian Medical Association has got two wings, IMA MS and IMA CGP, where this is a common platform where all these specialties interact. Now, you know, IMA is the mother organization where all the specialty members are members of all the specialty doctors are members of this association. So it is a common platform to have an interaction, to update the knowledge in each and every specialty. So also the general practitioners get more knowledge and updation from IMA CGP activities. And this year, Dr. Prashant and Viju Nelson has done an excellent job conducting this online as well as physical meetings. And I am very much happy and proud that Bhasi sir is taking the lecture today. He was my teacher at TDMC Alappuzha when I was a student, a BBA student there. And with that minimum words, I conclude all the very best to all the persons present over here, and congratulations, Prashant and Viju Nelson. Thank you.
Thank you very much, sir. Now, let me invite Dr. Viju Nelson, the State Secretary of IMA CGP Kerala State, for introducing the faculty.
Good evening, everybody. The Director of Studies, Dr. Prashant CV, our Chief Guest, and Dr. Bhasi S, incoming State President, Dr. Gokulam. Dear all, we had a teacher of teachers today for our academic session. It is none other than our Dr. Bhasi sir. He is an alumni from Trivandrum Medical College. He was the past HOD of General Medicine, Trivandrum Medical College. He had a short time with Amrita Medical College also. He was the winner of Best Clinical Teacher of APA as well as Gokulam Medical College. So we are expecting a fantastic session from our dear Bhasi sir. So with these words, I welcome the teacher of teacher, Dr. S. Bhasi, for this CME. Thank you, sir.
Thank you very much, Dr. Viju Nelson. Friends, now it is time for us to listen to the teacher, par excellence, Professor Dr. S. Bhasi. Hearty welcome, sir.
Good evening, friends. At the outset, let me thank Dr. Prashant and team for this opportunity. And now the monsoon has started and fever is very, very common, very well, including medical college. I think this is a very apt topic to be discussed today. Look. Initially, I have shown some paper cuttings highlighting the importance of fever, especially dengue fever. More. Now, this is noise. Forward. What? I know. That's on. Very good. Now, is there any relevance for this media, newspaper, TV, etc.? Now, one is advantage, that is, people will be made aware of the problem and they will be more careful. But there is a problem also because the death is projected, exaggerated in the media. So fear syndrome usually they develop. So in the public, so unnecessary referral to higher center by the general practitioners. And yet another problem is the administration and the politicians are also alerted with a plus point as well as a minus point. Next. Now I have included a few slides touching on the basics of clinical practice and physiology. Of course, any audience, if they think that it can be omitted, you are welcome. In between also we can interrupt. If you want to have good clinical practice, 4 C is important. Competency means your capacity to make a proper diagnosis, proper evaluation, and proper treatment the most scientific way, considering cost effectiveness, risk benefit ratios. Second is confidence. Unless you are confident, you will not be able to manage properly. And most important, of course, attitude, that is concern for the patient and family, avoiding over investigation, over treatment. And any problem, common sense is also equal, very important. Next. Slide movie is when you come to good clinical practice, the most important is a well-elicited interpretive history. Then focused clinical examination. Why I mention focused is, it is not possible to go into all details of head-to-foot examination, all system detailing practice, even though we teach the students like that. So second is a focused clinical examination depending upon the situation. For example, if it is a dengue fever, focused clinical examination, look for rash, look for fever, look for just a spleen, just backward spleen may be there. Depending upon the situation, if you are suspecting leptospirosis, focused clinical examination, looking at eyes for eye congestion, jaundice, and subconjunctival hemorrhage, like that. And targeted investigation, not all the investigation is available in the hospital lab. That is the best way of clinical practice. Next. And now diagnosis of any illness, most important is history. About 70% of the patients we can make a correct diagnosis by history alone. There is sufficient evidence based on scientific evidence which is published in the journal also, both outside India and India. And additional 10% we can make a correct diagnosis by clinical examination. That means a good clinician can make a clinical diagnosis 80% of the patients, and only 20% require investigation to the others, minimum investigation to confirm your clinical diagnosis. Now that is a very important quotation, importance of history by Sir William Osler, the most respected clinician of the previous century. Listen to the patient, he or she is telling you the diagnosis. Importance of history. Now technology is actually in skyrocketing field. Now technology has it's a double-edged sword. About 50% of the patients there is benefits, intervention, ventilative support, etc., and advanced investigations. But other 50, this is rough. Other 50%, it is actually disadvantage or investigation, or medication, or intervention like ventilation and other supports. But even for dying patient, you find so the 50%, it is actually a disadvantage. Fever the charm. What is the charm is making the correct diagnosis with clinically and minimum investigation and practicing the correct treatment only, avoiding over investigation. And the challenge is sometimes we find fever at very atypical presentation, you may miss the diagnosis or you may require a lot of investigation to confirm the diagnosis. A short fever is a topic for today. By practical sense, it is in, we'll say that it is less than 7 days. If you look at the literature, actually, such a definition is not there. But conventionally, less than 7 days, more than 7 days, a general practitioner naturally, he may prefer to refer the patient to a higher center. Now, I am touching a few basic physiological problems related to fever. If anybody generally felt that it is not necessary, you can indulge. Now, metabolism is temperature dependent within a narrow range. Other if a temperature is much below or much above, metabolism cannot happen. Body temperature is kept constant. Fever is one of the most common problem, and most fevers are over treated. Recording a temperature also, oral is the most ideal standard, and that is the oral temperature is the basis for recording the temperature in the temperature chart. And when you are using a mercury thermometer, 90 seconds. If you are using a digital thermometer, naturally you have a signal and usually less time is required. Axilla is the most commonly practiced one, but the problem is axilla temperature compared to very high variation. Average is 0.5 to 1 degree Fahrenheit. But the usual practice is most of the nurses will add 1 degree Fahrenheit and chart the temperature. There again, mistake is there. Sometimes you find the axillary temperature and oral may be 2 degree more than the axillary. So in general, the axillary temperature is not very reliable. Rectal temperatures are available, but very often not practiced because to do practical use. Another method is the tympanic membrane, external rotary meter. It very well practiced in the UK, especially in pediatric, but it is probably not so used in the Kerala. It is body temperature regulation. A few words. All of us know that there is a thermoregulatory center in the hypothalamus, which is and the hypothalamus receives signals regarding the body temperature from the nerves as well as on the blood which is circulating. And normal temperature, body temperature is always kept higher than the atmospheric temperature. We may, for example, sitting now in the AC room with a 23 or 24, but body temperature is 37. So that is maintained by the heat production. Actually, heat production in the body is much more than that is required to keep the temperature at 37 degrees centigrade. So if it is temperature, normal temperature is maintained by heat loss. The heat production is actually, heat loss is mainly occurring through the skin and lung. A word about pathogenesis of fever without going into detail. Fever is defined actually regulated elevation of temperature. Now what is happening is the hypothalamic set point, normally set point is 37. It is raised by presence of a pyrogen, which may enter the body from outside, we call it as exogenous pyrogen, or it may be produced inside the body, we call it as endogenous pyrogen. And when there is a set point is raised, for example, from 37 to 39, there is need for elevation. At that point of time, the hypothalamus senses that 39 is the normal temperature. So there is need for production of elevation of body temperature. That is possible by two ways. One, reduce heat loss from the skin. That is by vasoconstriction. Second is increase heat production by increasing the metabolism. Both are happening. And when there is vasoconstriction in the skin, you feel what you call pleural chills. And when there is a need for a rapid increase in temperature, and that is when it is rapidly rise to 40 degree, that is equivalent to 104 temperature, it cannot be increased rapidly by metabolism. So there is another method is by vigorous muscle contraction. That will be experienced as rigor. So rigor occurs when there is a need for a rapid increase in body temperature. Normal temperature, I just assumed, normal is average is 98.6, so variation is 98 to 99. Diurnal variation is 1 degree Fahrenheit, not present in all individuals. Maximum temperature is in the evening 4 to 8 p.m. Minimum is at the early morning 2 to 6 p.m. and the diurnal variation is always magnified when there is a fever. It may not be 1 degree, it may be more than. And these are the simple definitions which is given in the even the clinical methods. Normal body temperature is 98 to 99. Subnormal is less than 98. Fever is more than 99. And hyperthermia or hyperpyrexia is more than 107, equivalent to 41.6 centigrade. And hypothermia is less than 95 degree Fahrenheit. I was purposely use a Fahrenheit because we convert these figures into centigrade, all of them will be in decimals. And fever is regulated elevation of body temperature. There is nothing wrong with the hypothalamus. It is by a pyrogen, it is just elevated. That is all. It's still under regulatory control. Next. Now, this is important because when you treat these people, parameters are important. There is increase in metabolic rate with 1 degree rate. There is a 30% increase in oxygen consumption. That means actually you require long calories. Increase in heart rate average is 10 beats per degree Fahrenheit. That is also important, especially when the patient is having heart disease, heart failure, and coronary heart disease. Fluid loss, again important, average fluid loss is 200 ml per 24 hours plus 1 degree Fahrenheit. So if 4 degree Fahrenheit elevation average will be 800 ml of fluid will be lost. That means fever patient requires more fluid and you have to emphasize the intake of more fluid. Respiratory rate also increases. Chills I already mentioned, it is due to vasoconstriction. Rigor, again previously mentioned, that is a need for rapid increase and it is produced by the vigorous muscle contraction. Next. Now, taking the history of a short fever, and that is the most important one in making a diagnosis and finally deciding on treatment. Travel to an endemic malaria area may be important because the patient may be having malaria. If you go to some other North Indian state or any malaria, any fever, they will first think of malaria, but we don't think about it. If the patient is having nasal symptoms with a running nose, nasal congestion, nasal discharge, plus sore throat, naturally, unless what otherwise it is a viral, it's a very common virus. Blanching erythema in the body as a rash is present, it is almost always viral in it. If the patient is having a follicular tonsil, follicle is enlarged and with the follicle, tonsil is enlarged with follicles, and enlarged tender tonsillar node that is near the angle of mandible, and neutrophilic leukocytosis. It is classical of a bacterial tonsillitis, and unless whatever it is streptococcal, beta hemolytic streptococci, which is very sensitive to penicillin. Next. If the patient is having dysuria, loin pain, and tenderness in the lumbar region, sometimes palpation is suggestive of acute pyelonephritis, and naturally we proceed with the investigation of a first human examination and back. If the patient is having more than 5 to 7 days fever, gastrointestinal symptoms, sometimes with melena, and just a barcode spleen, consider the possibility of typhoid fever and investigate in that direction. Fever with the myalgia, fatigue, loss of smell and taste, upper respiratory symptom in the form of nasal and throat pain, consider COVID-19. Even now, COVID-19 is present with a less severe form. Patient is having fever, myalgia, muscle tenderness, subconjunctival hemorrhage, plus conjunctival congestion, and if jaundice is also present. Actually, the picture shows there is a jaundice as well as subconjunctival hemorrhage, plus an occupational history like exposure to contaminated water, that like a person working in the paddy field. It is very strongly suggestive of leptospirosis. Naturally, the investigation is only in that direction, not for other differential diagnosis. And then, of course, treatment is initiated pending the report. Next. Fever with myalgia, arthralgia, retroorbital pain, flushed appearance, erythematous rash, high possibility that it is dengue fever. Dengue fever is now very rampant in all hospitals. Fever with the body pain and a scar, especially in the hidden areas, genital areas, axilla, under the breast. And a scar is a classical one they showed in the picture with a black central spot and erythema thereout. If that is present, it is a very highly diagnostic of strep typhus. Only point is scar may be present only in about 50%. Even when other features are present, you have to think of that possibility because it is not very rare. And scar is easily treatable, especially in the early stage. Next. Relative bradycardia is often projected as an important factor. Unfortunately, it is very, very non-specific. It can occur in so many conditions like typhoid, leptospirosis, dengue fever, uncomplicated influenza, fever, raised intracranial tension or deep jaundice, brucellosis, and others. So it is a non-specific thing, not it. Most short fevers are commonest cause is viral. It is self-limiting, self-curing. Avoid over-investigation. Neutrophilic leukocytosis with the juvenile form, that is the band forms, and little earlier also. And toxic granulation of the neutrophil suggests bacterial infection. Neutropenia, usually it is viral etiology like dengue fever, other viral infections. It can also occur in typhoid, brucellosis, and any condition. So there is bone marrow suppression, including SLE. Atypical lymphocytes, you may sometimes call it as virocytes, is very common in viral infections. The maxi atypical lymphocytes are seen in infected mononucleosis and cytomegalovirus. But other viral infections like HIV, dengue, viral hepatitis, all can produce atypical lymphocytes. Because that requires a medical examination by a reasonably competent technician or preferably by pathologist. Technician is likely to give a wrong result. A pathologist is necessary to make it, or a clinician experience in seeing the peripheral smear during the training, it is okay. But generally, a pathologist report is important. Next. And leukopenia and thrombocytopenia in short fever sometimes produces a lot of worry for the general practitioners, especially in the periphery, the limited facilities, and sometimes even referral. The most important message is do not panic about it. Next. Leukopenia is in a short fever, is usually shortly, recovers spontaneously without any treatment. And remember that absolute neutrophil count more than 1,500, there is no risk of bacterial infection. No need for intervention. No need for referral also. It can be highlighted by next. This is highlighted by an example which I have seen previously. A 16-year-old girl, previously healthy, short fever, fever subsided. It was treated by the general practitioner in the periphery. Total count was 2,800 with a neutrophil of 54%. Smear few atypical lymphocytes. The general practitioner doctor was a little upset, thinking the possibility it is risky. So it was referred to medical college. And he was admitted. Absolutely okay. Symptomatic treatment only, no antibiotics even, and count improved after about 3 days and discharge. Because the 1,500 and above neutrophil is absolutely safe. If you look, convert that 2,800 with the neutrophil 54%, it is more than 1,500. So it is a safe level. Everything in the body, including the count, has got reserve, just like other organs. So a reduction in the neutrophil count or total count is not going to produce any problem at all, provided this is neutrophil is above 1,500. Next. Okay. Thrombocytopenia is another problem, one for concern, worry, and also for referral. It is common in majority of viral infections. It is shortly self-limiting, spontaneous recovery is the rule. Nobody will count more than 20,000 platelet. Spontaneous bleeding is rare. No indication for platelet transfusion. Definite indication of platelet transfusion is less than 10,000 or between 10,000 and 20,000. You can consider when there is significant bleeding. Next. Just to highlight this, a 20-year-old male previously healthy, 3 days fever, confirmed dengue, subsided, platelet count was 20,000, referred to medical college and admitted. There is no bleeding in any place. Next day count was 16,000, no bleeding. given only vitamin C. Of course, that is only a placebo. It's not going to do any wonders. Good. Patient improved and count also improved and discharged after 3 days. Look, can you get next question is can you get leukocytosis? And that is I think this is a very important slide. Initial 24 hours and sometimes up to 48 hours. If you do the blood count in a conventional viral fever, neutrophil leukocytosis may be seen, and that may be wrongly interpreted as a bacterial infection. On repeat count, it will return to normal after 2 days. So here the message is take the patient, not that the blood clot. And most important is avoid doing a blood clot on the first day unless there is an absolute indication. When the patient is not very sick, we can definitely, 3rd day is ideal time to proceed with the blood count in a short fever. Just to highlight that a 30-year-old male, previously healthy, admitted with 1-day fever. The total count was, before I saw the patient, total count was 12,200 with neutrophil of 80%. That is suggestive of a bacterial infection. Clinical examination, there was no abnormality, given only paracetamol. Repeat count after 2 days, count came to 9,000 with neutrophil only 69%, that is within the normal range. And discharged on the 4th day without any medication. He was given only paracetamol assays. Treatment of a short fever. Most short fevers are self-limiting and self-curing. Avoid over-investigation and over-treatment. Antipyretics and antibiotics are grossly misused. Is there any benefit of fever, temperature, body temperature elevated? There is some evidence that a fever decreases the virulence and pathogenesis of at least some of the infecting organisms. Fever also known to increase chemotactic and phagocytic function of the WBCs with a better bactericidal activity, especially the neutrophils. And complete suppression of fever may produce complications due to certain viral infections due to the decrease in their immunity. But this is described in the literature. But if you ask for complete evidence, probably controlled studies are not available. So complete evidence is lacking, but there is a suggestion. Antipyretics may not be used now. When you use it, paracetamol is safest. Aspirin can produce gastritis and bladder dysfunction. Aspirin in children can also produce Reye's syndrome, very serious problem. NSAIDs, when you use for fever, short fever, there are multiple problems to be avoided. We will discuss a little more about that. Now, one of the problems now we see is many hospitals, especially higher centers, any short fever, you give injection paracetamol as a bolus. Extensively used, but not superior to oral paracetamol. And remember that no injection is absolutely safe. It can produce pain, not only occasionally injection action, occasionally transmission other disease. You know that the recycling of syringe and needles even is already happening. Injection paracetamol on 1 gram is the heading on this is also practiced in many hospitals. Injection paracetamol 1 gram IV infusion or half an hour or so. It is commonly practiced. Effect lasts only for 6 hours. It is only symptomatic treatment. Cost including the trip set will work up to 650 to 700 rupees. It is as good as or as bad as oral paracetamol 1 gram, which will cost only 3 rupees. So whether we want 3 rupees antipyretic or the 700 rupees injection paracetamol is to be highlighted. Yes, next. And now another problem. Sometimes people with fever may be having vomiting and oral intolerance, and they have high fever, body ache, headache, etc. And they are definitely want a relief of antipyretic and analgesic property. You have injection paracetamol available. 1 ampule containing 300 milligram, and 2 ampule you can give it IV, a little diluted to saline. That is very effective. I have tried in many situations where oral intolerance was seen. It is available, and 2 ampule cost only 26 rupees. Plus, possibly the cost of the syringe may be mentioned 10 rupees. So that can be done. That is only really only a minority. Now, is there any disadvantage of antibiotics? The diagnostic clue from the pattern of fever is lost. Possible beneficial effect of temperature on infection is lost. Response to therapy cannot be affected, assessed, especially when it is a bacterial infection. You have started on antibiotics. For typhoid, you have started on appropriate antibiotics. Return of fever can occur with chills. When you give high dose antibiotic, temperature will come down to normal. It is already set to say 39 degrees centigrade. It is coming to 37. So need for rapid increase. So rigor will occur. That is iatrogenic virus. Excessive setting can occur with high dose paracetamol or antibiotic. It can lead to more fluid loss and BP fall can also occur. Fluid loss can be more than the fluid loss which is occurred due to fever alone. Next. Antibiotics definitely has to be given. People will definitely ask for. It is indicated when there is significant headache and body pain producing problem for the patient, not tolerating. Presence of coronary heart disease or heart failure. If your heart rate has to be brought down, otherwise it can worsen the heart cardiac problem. Nervous system dysfunction with the cerebrovascular accident, head injury, definitely you have to give because that will be worsened. Seizure disorder, definitely. Otherwise, seizure threshold will be brought down and risk of developing a seizure is. Young children with the history of febrile conversion, definitely temperature has to be brought down. Otherwise, the child may develop. And preferable to use in pregnancy because a pregnancy, even temperature itself is a disadvantage. Next. Now, you have 2 or 3 slides on NSAIDs. There are so many problems. And it is very good antibiotic, much better than paracetamol, and very good analgesic effect, but to be avoided because of multiple problems. Next slide, we come to that one by one. Next, NSAIDs. Gastritis and vomiting is the first problem. Minimal amount of superficial gastritis is common with all short fevers. And when you give NSAID like ibuprofen, diclofenac, etc., you have a severe gastritis with vomiting. Sometimes it may produce erosive gastritis or hemorrhagic gastritis with hematemesis and melena, which can be even fatal or you require blood transfusion. It could be. It is only symptomatic treatment. NSAID is not going to cure the fever. Next. Next problem. This is just to highlight that about an active student in Gokulam when I was a unit chief. He had a short fever, which is classical of upper respiratory tract infection, given azithromycin and NSAID by the junior resident actually. And he developed upper abdominal pain by vomiting. And he was admitted in the PA ward. Mother has to be, he was saying 60 minutes, and so IV fluid has to be given. All this could have been avoided if he was not given any time. So the problem was iatrogenic more than the basic problem. And the rule is your treatment and investigation should not produce more problem than the basic disease. And in fact, it just produced. There is no indication for azithromycin, which is well known to produce gastritis and vomiting. NSAID is very dangerous. Next. Acute renal failure is well known with all NSAIDs. 2 mechanisms are acute. Chronic well known analgesic nephropathy. Long-term use can produce irreversible kidney damage called analgesic nephropathy. But acute use even for a few days can produce. Even a single dose occasionally can produce. One is hemodynamically mediated by vasoconstriction of the kidney vessels. Second is acute interstitial nephritis. It is known to occur with many NSAIDs. So this is again NSAID short fever. It is only producing a symptomatic relief, so it has to be avoided. And more important, some of the acute febrile illness like leptospirosis, dengue fever, scrub typhus, and typhoid is well known to be associated with renal involvement. Of course, not amounting to renal failure, but you know the renal parameters, some abdominal, urinary abnormalities are there, RBC may be there, vessels are there, albumin may be there. This condition usually renal failure is usually not very prominent. Leptospirosis, renal failure can occur, scrub typhus, renal failure can occur. So in the beginning, people may not know whether it is lepto or scrub or things like that. And if you give NSAID, the renal problem will be worsened and you can be sued also. Renal problem they can attribute because of the NSAID, maybe because of the basic disease itself. So the next problem with NSAID is it is having antiplatelet effect. And many short febrile illness are associated with the thrombocytopenia. Well known, dengue fever, leptospirosis, scrub typhus. many acute viral infections, typhoid fever. All these people can have thrombocytopenia. And when you give already given NSAID, this will be worsened. Next. Hepatotoxicity, mild hepatotoxicity is well known with all NSODs. Nimesulide, of course, now it is withdrawn, was notorious for this hepatotoxicity and even fatality has been described. And remember that many acute febrile illness, on the first day, second day, we don't know what it is. It may be the beginning of an acute viral hepatitis. It may be the beginning of dengue fever, leptospirosis, staph typhus, Henry fever, infectious mononucleosis. And many of these viral infections, some amount of hepatic involvement is very common. And an elevation of SUAT and SCPT is very common in many viral infections, more prominent in staph typhus, dengue fever, and infectious mononucleosis. So NSAID will worsen that. Now, role of antibiotics. I've already mentioned that majority of short fevers are viral, and antibiotics has very little role. The dictum is fever to be treated with antibiotics, paracetamol only, if needed, and not by antibiotics. More short fevers are viral, no need of antibiotics. It is grossly misused. No need for prophylactic antibiotics. Response after starting antibiotics does not indicate bacterial infection, and the result is due to bacteria, because majority of viral infections, duration of fever maybe 2 days or 3 days, or even less than that. So response does not mean it is because of the antibiotics. Patient may believe that, at least around this does better not to believe. I use only clinical or investigation evidence of bacterial infection. Bacterial pharyngitis and tonsillitis, antibiotics follicular lesion of the tonsil, tender tonsillar gland, neutrophilic leukocytosis. Drug of choice is penicillin, amoxicillin may be alternative. And penicillin sensitive patient, allergy patient, a macrolide like erythromycin or even azithromycin. Next. If you are suspecting leptospirosis based on clinical clues, I already have shown the fever with body pain, muscle tenderness, eye congestion, subconjugal hemorrhage, jaundice. And when you do an LFT, alteration is invariably seen, RFT, minimal alteration is seen, urine examination is usually abnormal with the trace of albumin, few RBCs and vessels. So these features are present. It is highly suggestive of leptospirosis, especially with the history of contact with contaminated water, life farmers, and other people cleaning. You are, even before confirming, we can start treatment for leptospirosis. And then do mild leptospirosis, treatment of choice will be oral doxycycline, 100 milligram twice daily. Tolerating orally. When the patient is having more severe problem, injection glycerin penicillin is a drug of choice, but unfortunately, glycerin penicillin now available not. So other antibiotics, all antibiotics are actually effective, including ceftriaxone, quinolones, ampicillin, amoxicillin, all of them are effective against leptospirosis. Next. Suspected staph typhus, we already mentioned, fever, myalgia, thrombocytopenia, hepatic involvement, scar is present. So some renal involvement is very common, and you are justified in starting treatment for typhus. The drug of choice is doxycycline, 100 milligram twice daily, to be given for 7 days. But other antibiotics also effective, like chloramphenicol, azithromycin, and selected cases rifampicin, and other tetracyclines. The drug of choice is definitely doxycycline. But meningeal involvement, sometimes you have to go in for chloramphenicol. Next. Dengue fever, common, usually self-limiting. Thrombocytopenia and leukopenia are extremely common. In fact, leukopenia occurs much earlier than thrombocytopenia, and spontaneous recovery is the rule. No need of intervention. Platelet transfusion is not needed in the vast majority. No antibiotics or no steroids. Next. Steroid in dengue with the thrombocytopenia, many people are using it. It is absolutely useless and positively harmful. No role except in complication. That is a very rare complication. I have not seen one with a dengue fever, and not to be discussed further. That is macrophage. I'll go and skip that. I'll skip here. Skip here. Now, platelet transfusion in thrombocytopenia, dengue, spontaneous bleeding I have already mentioned again at repetition only with the count more than 20,000 spontaneous bleeding is very, very rare. Platelet transfusion is useless when is absolutely when indicated when the count is less than 10,000 or if bleeding with a little hair count. But remember that no blood or blood powder transfusion is absolutely safe. So it has to be given only when absolutely indicated. Why I say absolutely is not safe? We are doing only screening for the screening test for HIV, hepatitis C, hepatitis B, etc. And screening test is not foolproof. You know the window period also. For a small chance, a very small chance of patient developing hepatitis B or C or HIV after blood transfusion, even after screening. That is why no blood transfusion is absolutely safe. So use it only when absolutely indicated. And absolute indication thrombocytopenia if the count is less than 10,000. A case scenario 34-year-old male, previous proved dengue fever, platelet count was 40,000, minimal gum bleeding, no petechiae, no purpura, no other bleeding site. Examination patient at this was a Gokulam issue when I was a unit, he was admitted in the ICU with the unit chief by the UTMO. Actually, he would have been managed in the ward. Gingivitis was present, so I started a dental opinion. Topic and medication improved. No platelet transfusion given. Count also improved. The point was there is only minimal gum bleeding without petechiae purpura, and the platelet count was 40,000. With 40,000, bleeding is very, very rare. But there is a second. The message is very learning point. Next slide. The learning point is platelet count more than 20,000, especially like 40,000 and all. When there is a bleeding from a local site, consider local pathology, and that was the situation in this case. Now influenza is common. I've heard about influenza. Commonest type of influenza is influenza A, and depending upon the antigen, you have H1N1, that is, and H3N2. H3N2 is the most common circulating. H1. Influenza is also now coming. Not in the pandemic situation. A few cases are there. Influenza B is the other one, less common, and generally less. It is also there, but it's much less common, generally less severe. Influenza can be sometimes very severe problems. Influenza treatment is based on the ABC categorization. Category A is a mild patient. They can be treated at home with the minimal symptoms only. Category B1 and B2, they can be treated at home with the daily monitoring and over the phone or reporting to the doctor. And category C, severe illness, usually with the complications like pneumonia, hypoxia, etc. And all C, category C has to be admitted in the hospital, carefully monitored and treatment. Next. Testing for virus of that is PCR, that is nucleic acid testing for influenza. All patients in the category C patients you have to test. All hospitalized patients you have to test. Other category, it is optional. If they are treated at home, isolated at home is okay, because this immunization is costly, not present everywhere. So it's not a mandatory. Next. Antiviral treatment for influenza, the drug of choice is oseltamivir, 75 milligram twice daily into 5 days is standard. All category C, you have to start. Category B1 and B2, also there is recommendation. And pregnancy also, oseltamivir must be done. So influenza, if you suspect influenza, except category A, there is indication for oseltamivir even without confirming the diagnosis of influenza by nucleic acid testing. Next. Misuse of antibiotics in short fever, majority are not indicated. The problems are what? Drug toxicity. Second is increase in the cost of treatment. Third is development of drug resistance. And the fourth is superinfection. Superinfection, if anybody is not familiar with the term, it is very simple. When you are giving a broad spectrum antibiotics, especially for a longer period, the normal flora will be eradicated from many places, including the oropharyngeal placia. That will be colonized by the hospital strains of multi-drug resistant bacteria like Klebsiella, Pseudomonas, E. coli, Acinetobacter, etc. And that may produce infection later, and sometimes fungal infection. Overuse of drugs in fever is very common. Not only beneficial, positively harmful. And again, I am just quoting William Osler, a little exaggerated statement. Person who takes medicine must recover twice, once from the disease and then from the medicine. This is a century ago, he has highlighted that the medicine producing iatrogenic problem is very, very common. So you use medicine very carefully. Next. Again, William Osler, the new physician start life with the 20 drugs for each disease. The old physician ends life with one drug for 20 diseases. Of course, that is a little exaggerated statement, but the message is very, very simple. When you are more experienced, more competent, more confident, more concerned with the patient and family, and following scientific treatment, many patients can be treated without medicine. That is also true. Many viral infections, short fever, that no need of any medicine. I've already mentioned that antibiotics are not always necessary. Mild fever, not much of headache, not body pain. The individual is tolerating it. After discussing, paracetamol, SOH, it is left to them whether to take it or not. So you can treat short fevers without any drug. So this statement is definitely okay. Next. Yet another problem when you use drug is drug-induced fever. Not uncommon. Antibiotic they started for fever. Fever continues due to antibiotics is very common. Penicillin and cephalosporins are notorious to produce drug-induced fever. Other drugs like sulfonamide, nitrofurantoin, anti-TB drugs, anti-epileptics also produce fever due to the drug. Next. I don't know. Drug fever usually starts 5 to 10 days after starting drug, but occasionally it may start after the first or second dose also. Next. Just to highlight that point, a case scenario, a middle-aged professional, husband of a medical college professor. This was a situation when I was in Amrita for about 4 years. He came with fever to me. Examination, there was nothing abnormal. He was started on injection ceftriaxone empirically, suspecting typhoid fever, and fever continued. A subsequent evaluation, there is no evidence of typhoid fever. And all systems are normal, investigation is normal. But fever continued. So what I did was stop ceftriaxone, and after about 24 hours, fever subsided. Many examples slides. Now, next 2 slides are very, very important. Do's and don'ts in short fever. Next. What you must do, explain the natural history of self-limiting thought febrile illness to patient and relatives. Reassure them. Give oral paracetamol for fever and pain when necessary. Discuss the availability of more potent and more toxic analgesic and antiarrhythmics like NSAIDs. It's available, but you can tell that it produces more problem. I have done it several times, even during the chikungunya. Many people said, okay, we are happy with the paracetamol only. Next. So this is very, very important. After discussing, I know the problems, people working on the general side, especially government hospital, how much time to get. I will get time. I am very practically aware that in a government hospital, government health center and all, 150 patients seen by one doctor. This is not at all possible, not fully aware of that. But I am just projecting what is the first thing which you can do, which I will be able to do now because I am seeing only small number of patients. What you should not do in a short fever is what over investigation. Injection paracetamol, onga, IV, absolutely useless. It will only reduce a fever for 6 hours. Antibiotics, vast majority, that we can definitely do. I know many general practitioners, my close friends, are not using antibiotics for short fever. NSAIDs we can definitely avoid, there is no problem at all. The first thing is you can say NSAID is available, it is more potent analgesic and headache will be less, fever will be less, body pain will be less, but it can produce sometimes very serious and even fatal problem. Do you want it? Many people say, almost everyone will say no. Blood and blood powders, use it with daughter portion. I repeat again, no blood transfusion is absolutely safe. Unnecessary referral must be avoided. That also requires, of course, the public is responsible, patient, the family may not very happy with, many of them are right, they will ask for referral. There are a lot of problems. Proton pump inhibitor is routinely used when you want to give a paracetamol or when you give an antibiotic. Remorsal is not absolutely necessary. Exaggerating complications related to leukopenia and thrombocytopenia. Sometimes periphery, there are a lot of problems. I was always working in a very coli. I was protected by the walls of the institution. The situation may be different in the periphery. I fully agree that. So you may have to refer also, that is also fully accepted. But if you are capable of telling the patient that this is likely to, it's okay. Now a lot of litigation, lot of NASA, etc. coming in the media and all. Lot of problems are there. Next. Now finally I will conclude by a few take-home messages. Most short fevers are self-limiting. History and clinical examination, most important, you can make a diagnosis. Many patients do not require any investigation or maximum only blood counts. And elderly patient, of course, if you are doing yet another investigation, it can be a blood sugar because he may be having an undiagnosed diabetes that will cost only 35 to 40 rupees only. Avoid over investigation. Treat for fever with antipyretics and not with antibiotics. Paracetamol is the safest antipyretic available. Use it when indicated and orally sufficient in the vast majority. Avoid NSAIDs. I am repeating again and again. Avoid NSAIDs in all short fevers. Antibiotics to be used only with the clinical or investigation evidence of bacterial infection. I want to just warn again that if you do the blood count on the first day of viral fever, neutrophilic leukocytosis will be there. That will be wrongly interpreted as a bacterial infection. Next. Thrombocytopenia, not the main factor predicting the severity of dengue fever. I have never seen a patient dying in the medical setup, dying because of bleeding. The reason for mortality in dengue fever is one, severe capillary leak producing hypovolemia, hypotension, and shock. Second is the cytokine storm occurs in a small percentage dengue fever producing multiple organ failure. And third is rare complications like dengue encephalitis. So dengue fever death mortality is seldom due to thrombocytopenia and bleeding. So that is not to be highlighted, but the other thing, the capillary leak with the hypovolemia, hypotension, shock, and the cytokine storm which is producing organ failure, multi-organ failure, independent of the leukopenia or thrombocytopenia, and the blood loss. That is the reason for mortality and rarely dengue encephalitis. That is the reason for mortality. So thrombocytopenia is not the most serious. That has to be again and again re-emphasized because many patients will come say count over. Only count is projected. The other things are not so important. Next. Avoid steroids and all short fevers. Avoid unnecessary platelet transfusion. Again and again repeating because many people are doing it. Even in high-tech Sundays, even when the platelet count is 30,000, 40,000 people are using platelet transfusion. Next. Again, last slide, I think. Do no harm. The most important aspect of ethical principles. Medical ethics, the most important is do no harm. Avoid blood and blood transfusion. This is I have probably repeated the 10th time. Avoid antibiotics unless indicated. No, it is repeated many times. And repetition sometimes is necessary. Thank you all for the participation. Once again, thank Dr. Prashant for this honor.
Respected Bhasi sir, thanks a lot for being here at IMA headquarters, coming over here, addressing all the doctors, all the members of our profession. Dear friends, now it's very clear about our approach to the fever. Now the time is of fever, and it's time for you to unmute and ask questions.
Any question is welcome. No need of inquisition. No need of hesitation. Not only question, there may be senior faculty members in the audience, they can make up the contribution also from their experience.
Sir, what is the current relevance of Vidal test?
Vidal, one, it is sensitivity and specificity is not very good. It has got a, definitely it has got a role in typhoid fever. Only thing is single value making a diagnosis is often difficult, provided you are doing it hourly. Suppose a patient comes on the end of second week and the clinical picture is suggestive typhoid fever, and Vidal comes both TO and TH in high dilution, like 1 in 400, 1 in 800, or 1 in 1600, then definitely it has got a significance. But a low titer of Vidal, it is not at all suggestive of typhoid fever. I already mentioned it is one sensitivity is poor. That means all patients typhoid, Vidal may not come to significant positive level. Specificity is poor because Vidal 20 positive without typhoid, even when there are other infections are present.
In between, let me update you on the coming week session. And next week, we are starting with pulmonology sessions, and we'll be, moving between the topics.
Sir, can I ask you a question? I'm Dr. Shamdi
Dr.
Gopal.
Shamdi Gopal.
Most welcome.
Yeah. Sir, first of all, it was an excellent presentation.
Thank
Two
you.
questions I want to ask. One is, you told about paracetamol and the other extreme NSAIDs. Where does the mefenamic acid or mephthal it stands? Second,
Mefenamic acid is definitely an NSAID. I don't use it.
Yes,
There are
sir.
some people using it.
Does it has the same issues like other NSAIDs
It has got the same issues, a little less when compared to diclofenac
and others?
and naproxen, etc. It's a little less, but it belongs to NSAID class.
Okay. Next question is, sir, you said below to 20,000, usually the bleeding is rare in dengue fever.
Above 20,000.
About 20,000. So suppose there is a situation, the platelet count is around 20,000 and the lady is having her menstrual cycles. Have you come across such a situation, or this can worsen that?
Definitely. I have come across a few situations. 2017, there was a dengue epidemic all over Kerala. At least a lakh of people in Kerala with the dengue fever. And at that time, I was working in Gokulam. Gokulam itself, we had 3 months statistics was nearly 2,000 patients. Dengue fever. I had 3 or 4 patients in our unit with menstrual bleeding more than that. One of the problem which I was observed was, another reason for bleeding is coagulation factor, coagulation failure. Coagulation clotting factors, because maybe the mechanism is not clearly. One of the mechanism is where it's capillary leak or clotting factors produced by liver, which is a short half-life. It may be excreted in the urine one. And then there are other mechanisms also possibly. Whatever it is, there is, in addition to thrombocytopenia, there is coagulation failure. And it's easy to diagnose. There is something called mixing study. Mixing study is very simple. You do the APTT of the patient. Let's suppose it is coming at 70 or so, which is high. And then take the mixing study means 50% the patient's plasma and 50% normal plasma, and repeat the test. I will request the pathologist to do it. And 2-3 cases, it was definitely coagulation factor. Then the indication is fresh frozen plasma. Of course, even without that, when there is menorrhagia, you may bring down the threshold a little higher. You may give better transfusion.
Okay. Thank you, sir. Thank you, sir.
But they better roll out this also, the coagulation. It is not rare.
Other causes.
It's not rare.
Yeah.
Mixed studies, in any center we can do it, mixed study.
Okay. Yes, sir.
Patient plasma and normal plasma, repeat APTT. One case still I remember into a 68 or so initially, and it has come down to 42 after the day. And it is available in 1 hour, they will give the result.
Okay, thank you, sir.
I have personally contacted the head of the pathology department and requested for the mixed study.
Okay.
Sir, there are 2 other questions. What do you do in case of allergy to paracetamol?
Allergy to, I have already mentioned that antipyretic is not a must in any fever. Rapid swelling is the first choice. Tepid swelling is enough for throat fevers unless the fever is very high.
What is the maximum dose of paracetamol per day and the duration between the doses?
The duration of action of paracetamol is 6 hours. If you want round the clock effect, 6 hourly is a classical dose. Maximum recommended dose for adult without renal failure, without liver failure, dysfunction is 4 grams. That is 1 gram 6 hourly. Very often we need not have to go to the max. Throat fever treatment maximum dose is thought. Your idea should not be to bring down the temperature to 98.6. The idea must be to bring down the temperature to say that it is around 100 degree or 99.6. And the patient is relieved of the severe headache and body pain. That is idea. It is not, idea is not to bring down temperature to normal and keep it normal throughout. That is not the idea. The exception I already mentioned, patient is having significant severe heart failure or continuing angina after myocardial infarction. Their heart rate has to be controlled because of metabolism has to be brought down. So you have to give 6 hourly paracetamol to keep the temperature near normal and the heart rate also near normal. That is at the other interest.
Sir, can you mention about use of steroids in thrombocytopenia?
Absolutely not indicated.
Sir, there is an interesting comment from a general practitioner. He says that there are a set of patients who comes and says, I have fever, but my fever will never come outside. It's inside. And they will come with symptoms like body pain. How do we manage them?
Treatment, you have to discuss. There is nothing called the ulpani, internal fever. There is nothing. Scientifically, there is not. You have to. Fever means elevation of body temperature. That has to be recorded. You may not feel it, so you have to record. Sometimes when you feel that the skin, there may not be fever, but you record. That is it. Other ulpani, that is really a fever. So you record the temperature and show them that temperature is normal. Once it is oral recording is done properly, temperature is there is no fever. So you have to explain what is the science of that. And so it will that is called a
Factitious fever.
Factitious അല്ല. It is not our പനി പോലെയുള്ള ഫീലിംഗ് ഒരു ടേം ഉപയോഗിക്കാറുണ്ട്. ഫെബ്രയിൽ ഇത് ഫീലിംഗേ ഉള്ളു. There is no fever. പനി പോലെയുള്ള ഒരു തോന്നൽ. അത് അവരെ കൗൺസിലിംഗ് ആണ് ഇമ്പോർട്ടൻറ്റ്. Psychological feeling. You have to explain that in science there is nothing called ulpani. Record temperature. വെറുതെ തൊട്ട് നോക്കിയാൽ പോരാ. ഓറൽ ടെമ്പറേച്ചർ റെക്കോർഡ് ചെയ്തിട്ട് 98.6, 99 താഴെയാണെന്നുള്ള അവർ ഡെമോൺസ്ട്രേറ്റ് ചെയ്ത your temperature is normal, not body. If you have body pain, there may be some other reason. Investigate for that.
So there is another
You cannot say that you have no body pain. Body pain is complaint related, body pain is scientific. You can only say there is no fever scientifically. You look for other cause of body pain. Sometimes the body pain disappear after respiration.
There is another question. It says, so before going forward, I just forgot. Next Thursday, the session by IMA CGP Kerala is on COPD, chronic obstructive pulmonary disease, the management, prevention, early detection, prompt management, and particular focus on follow-up of COPD patients within the general practice setting. The session will be handled by a much learned, very great professor of pulmonology, former professor and HOD of pulmonology, Professor B. J. Prakash. Okay. Before that, there is one more question. Bhasi sir was telling whether it is J. Prakash. He is such a nice teacher, well known to everyone. Yes, sir.
That's the policy.
Sir. There is one more question to Bhasi sir. Like, when the patient presents with fever, so the question is, day 1 fever, day 3 fever, day 5 fever. Can you just enumerate essential investigations to be done?
On day 1 fever, unless there is indication for any major illness, organ involvement, other findings, no investigation at all. If there is dysuria, of course, look for urine. But remember, mild dysuria can occur in febrile state. I have already mentioned that fever, there is loss of water. So when there is lot of water, mild dehydration, urine becomes concentrated and urine becomes hot and it becomes more acidic. So acidic hot urine, concentrated urine can produce mild dysuria. So mild dysuria can occur in a febrile patient. The water intake is not compensating for the water loss. So that can be confirmed whether it's infection or not by simply looking for a urine microscopy. And pus cells are not present more than 5 or 6 per hypo. Naturally, it is not urinary infection. Otherwise, in the absence of organ dysfunction or other critical findings, no investigation should be done on the first stage. Third day, of course, the fever is there. In our scenario, majority of patients will and family would like to have some investigation. And the first investigation you can do is a complete blood count. CBC is okay. CBC will include everything: total count, hemoglobin, platelet, ESR, everything is there. And some of the laboratories, the cost is also not very high. And whether you are dividing it also, so that will give, including platelet, everything. And that will give a growth. Third day, if the count is normal, lower limit normal, or mild decrease with the mild thrombocytopenia, mild neutropenia, it is classical finding of a viral infection. And if they want further investigation, you can ask for a peripheral smear by the pathologist. But majority it is not indicated. But peripheral smear reported by technician means all sort of nonsense will be written there. So it will confuse you. A wrong investigation result is more problematic than no investigation. Wrong test is definitely more dangerous than no test. So that will be the third day investigation. Of course, if then investigation is, I have mentioned, targeted investigation. Targeted investigation means depending upon the clinical picture. That is our investigation which you will do. If you are suspecting dengue fever, first 5 days investigation of choice is NSN antigen by ELISA. If that is positive, it's 100% dengue fever. First 5 days. So not the day of onset of fever. If it's less than 5 days, NSN antigen and not antibody. And the heart test is not always reliable, false positive and false negative. The cost between cost and ELISA is not very much different. And after 5 days, if you are suspecting dengue fever, you must do the IgM antibody by ELISA method, because that is a method. Again, heart test is not always reliable. Heart test you say just positive and negative, whereas the ELISA will tell you the value. If the antibody comes as 70, 80 high value, it is almost always dengue fever. But just positive means borderline. The 11 is a cutoff point for dengue IgM antibody. So that also may give just a positive result, so that's not labeled. So that is about dengue. If you are suspecting lepto, investigation choice will lepto IgM, plus the other investigation, urine examination. Lepto you are suspecting, it is also better to either partial or a complete LFT, because some abnormality in the LFT is common, transaminase elevation, not very high. It may be 200, 150, 250, 300, whereas in viral hepatitis it will be in thousands. So, and the renal parameter, creatinine D must also be done. Mild elevation of creatinine is very common in leptospirosis. So urine few pus cells and RBCs, and 1 plus albumin, plus transaminase elevation, minimum elevation of bilirubin. If these parameters are present, it is a very, very high possibility that it is leptospirosis, especially clinical picture with eye congestion, mild jaundice, body pain, muscle tenderness, etc.
Sir, in the era of geriatric population, hike in geriatric population, do you suggest any special precautions to be taken in geriatric patients with fever?
Geriatric patients, you cannot take it as a geriatric means age above 65 or 60. When some people say above 65, some people say above 60.
Escalated.
Okay, and now people now say that it is more than 70. Like that, it will go in. The PH also, that's how age of this. First point I would like to say is age is only a number. Age is only a number. Many of people may be knowing my age. Anyway, I am not going to pronounce it down. So I definitely belong to the geriatric age group. But geriatric person without any common, no diabetes, no hypertension, no heart disease, no liver disease, no kidney disease, eating normally, doing regular exercise, sleep normal, and he's healthy. You find you go to Japan, especially in the Okinawa Island, there are many people about 100 years, very healthy, active, doing work. So geriatric population you may divide into healthy age people and unhealthy. Healthy not much of difference. If it's unhealthy, depending upon the situation, you may do the investigation little earlier. Because deterioration can occur rapidly in a geriatrics. Recovery will be slow. Young children, deterioration can occur rapidly, but recovery also rapid. So that is the main difference between very young and the geriatric. So unhealthy geriatric, definitely investigation will be little more you have to do. You should not miss. You cannot wait and watch, because can be very dangerous.
So fever with the butterfly rash on face, what could be the need?
Butterfly rash on the race and fever, it is understood otherwise SLE. In Amrita, I have diagnosed one case of SLE in the OP. Patient came to the OP, young lady, and he had a anemia, vague multiple symptoms, and low-grade fever also. And he had a butterfly rash in the butterfly that in the side of nose and side of cheek. So OP diagnosis was a SLE. And he was admitted, and ANA was positive, DFTNA was also positive, and APLA was also positive.
Right. Sir, in pediatric population, patients presenting with febrile fits in general practice setting, do they need to start antibiotic? There is a trend of starting antibiotic, and febrile fits is seen.
Febrile, of course, I can never practice pediatrics, but the question can be answered. A pediatric patient also with febrile convulsion, you have to give antibiotics and not antibiotics. Antibiotics around the 6th hourly, but keep it better temperature and the lower.
Sir,
Antibiotics not indicated.
sir, one more question. In the immunocompromised setting, like cancer, with the patient having, cancer is controlled or cancer is on chemotherapy, there are two situations. And in either situation, and a patient presenting with fever, the approach.
That is a very, very complicated question. Cancer on chemotherapy means it can produce one neutropenia. Severe neutropenia, that two types. One is below 1,500, but above 500. That is a moderate. Below 500 is severe neutropenia. Severe neutropenia, if it is persisting for more than a week, it is very high risk of Pseudomonas infection, fungal infection, especially Aspergillus, Candida, etc. That means it has to be watched very carefully. And they may have to give prophylactic antibiotics also. Ideal treatment, the recovery is observe very closely. If there is no fever, you can wait. The first onset of fever, take the blood for culture, and then start antibiotics is a standard. Regular prophylactic antibiotics is not recommended even for cancer on chemotherapy. But close observation. At that time, masterly inactivity. Then the first episode of fever, you record the temperature, fever is present, take blood for culture, aerobic and anaerobic, and occasionally fungal, and then start antibiotics. That is the ideal recommendation, the ideal situation. The situation is not ideal. Sometimes you may give prophylactic antibiotics, but the count is very low. Anti-Pseudomonas coverage must be given.
Sir, we are coming to the end of the session, but every academic session do need to have some amount of revision. Revision is very important. Last week we discussed about history taking, and actually when we discussed about history taking in medicine, Bhasi sir briefed us many important points. Okay, sir, see, when we review that portion, even the masterly, I remember the discussion about masterly inactivity. Like, it's not a period of inactivity, but activity. Can you share a few thoughts on history taking?
When you say masterly inactivity, you very closely observe the patient for development of symptoms, signs, any complication. That is called masterly inactivity. Because when we were actually medical students and PG students, myocardial infarction, there is no drugs available, and people used to call this masterly inactivity. Now it has gone to aggressive intervention from the day one, or day hour one.
History taking.
History taking, I think many things I have highlighted in the history.
Okay.
Many situations. But majority of patients, there was an article published in BMJ, a study conducted in UK, and that showed that 70% we can make a correct diagnosis by history alone, and additional 10% by physical examination. And interestingly, the BMJ study, the remaining 20%, Some of them were actually psychogenic problems and not really organic problems. And 2-3 patients, they could not come to a diagnosis even after all the investigations done. So
Thank you.
that means finally concluding about 85 to 88% clinical diagnosis. Okay. Only the remaining investigations were needed.
Thank
History
you.
is the most important. History is the most important. I will just highlight one point because Dr. Prasad was asking about highlighting history. I was in Alleppey. At that time, I had limited consultation at home between the evening only and 100% ethical. No connection with the hospitals. Everybody knows. One patient, young, around 40 years, came to me and said he has a valvular toothache. He consulted 2 senior dental surgeons. Both of them examined said that there is no dental problem. There is no gum problem, there is no dental problem. So complaint was toothache. So he came to me. Naturally, when the patient comes to physician, I was at that time senior assistant professor with more than 20 years experience at that time. I asked where is the pain. He was saying he is a pain is here and here. Actually, it was not toothache, it was lower jaw pain. It was lower jaw pain. And then I asked, when do you get the pain? Then he started saying that walking uphill, I used to get the pain. അപ്പൊ എത്ര സമയം നിൽക്കും? അത് ഞാൻ അവിടെ കുറച്ചു നേരം നിൽക്കും, 2-3-4 മിനിറ്റ് നിൽക്കും, അപ്പോഴത്തേക്ക് വേദന മാറും, പിന്നെ വേദനയില്ല. അത് കഴിഞ്ഞ് പിന്നെ അടുത്ത ദിവസവും വേണ്ട കയറ്റം കയറുകയാണെങ്കിൽ വേദന ഉണ്ടാവും. So diagnosis is very obvious. Any suggestions regarding diagnosis? Somebody having lower jaw pain occurring only on walking uphill and relieved by taking rest for about 4 or 5 minutes.
Must be angina.
Very good, very good. That is effort angina. It is present. It is present for more than 2 months. So we can call it as chronic stable effort angina, chronic coronary disease, and the entity is chronic stable effort angina. So treatment is definitely naturally you look for he was a smoker, he was a hypertensive, risk factors were present. So you treat the risk factors and give anti-angina drugs. Usually medical treatment is present stable for 2 months. So usually medical treatment is okay. Some of the cardiologists, of course, there is nothing wrong if somebody goes in for if the patient and relatives want an angiogram and make the diagnosis and angioplasty, that is also. But usually this type of problems, medical treatment is okay. That was once. Another situation was my own classmate, professor of ENT. Rainy season, early morning, he had profuse sweating. Profuse sweating, and feeling a little tiredness. Nothing else. No dyspnea, no chest pain, nothing else. Of course, he was an older, trained ENT surgeon, not the newer things. So he himself thought it could be cardiac. So he went to Cosmo, went to Dr. Professor Koshi. Dr. Koshi, cardiologist, retired professor of cardiology at Gokulam, and now senior consultant Cosmo. So he admitted, took an ECG, that was normal. Troponin done, negative. But Dr. Koshi said, we will observe you for a few hours. 2 hours later, an ECG was taken, and that showed pictures of acute myocardium. And he was taken for angiogram that showed a occlusion, and a primary angioplasty was done. And this has happened about 2 years ago, and absolutely after that, absolutely. So the presentation is only setting only, nothing else.
Can you share a few words about fever example?
Fever example, fever example. Any fever with exanthematous rash, dengue or example. Measles another example. Many other viral German measles example. Other chickenpox another example. Then there are so many other hemorrhagic fevers where that is also included under example.
So there is one last question. There are a few patients coming to a doctor after starting antibiotic from over the counter, which is actually banned right now. Okay, there is one situation. Actually, I am reminded of a staff coming to my OP today saying that some feverishness and some problem. And some nurse has given a sample antibiotics from the OP. And I discouraged her and I just gave her some support medications and even that only if necessary. Remembering the discussion that we had previously. So the question is, such counter antibiotics once started, do they need to stop or allowed to continue?
It has to be stopped, no doubt about it.
Okay, sir. That's the
Stop.
okay. It's high time for us to stop. Dear friends, thanks a lot. May I join with you all to thank Professor Dr. Bhasi sir to come all the way to Indian Medical Association Kerala State Headquarters to address the general practitioners and share his wisdom. I should say, share his wisdom in a bold way so that there is no ray of confusion regarding the management of the short film. Thank you very much, sir. We are greatly indebted. Thank you very much.
Thank you, Bhasi.
Yes. And dear friends, we thank IMA Kerala CGP chapter. Thank each one of you for joining us in this academic venture. Kindly note that these sessions are recorded and it will be placed in IMA Kerala official YouTube channel with immediate effect. Thank you all. Good night.
Thank you.
And I recognize the presence and interaction of Dr. Shyamdi Gopal, Senior Leader of Indian Medical Association and current State Secretary of the IMA schemes. Professional Protection Scheme. Thank you, Dr. Shyamdi Gopal. Thank you all. Good night.
Thank you all.